So, this is titled Tips for Primary Care, but actually the information in this applies to people who are treating people in hospitals and other settings as well. I'm a psychiatrist and an internist, and I don't have any financial conflicts of interest. So I'm going to talk a little bit about depression. I'm going to offer a different way to consider how to make the diagnosis rather than sort of what is most commonly talked about. I'm going to actually base this on the ICD-10 criteria, which are actually what providers use to bill. And I think it might be a better way to look at the symptoms sometimes. I'm going to also, I don't have time really during this presentation to talk about suicide so much, but I did put some resources at the end of the presentation for people who have a special interest in that topic. It's a very important topic, and older adults are the highest risk for completed suicide, though that may not always be related to depression or mental illness. Most of the time it is. And before I delve in, I just want to point out most people successfully age. Successfully aging is unrelated to whether you have any particular illness or not. And even if you have major depressive disorder, you can successfully age. And most older adults really do age that way. So I don't want to make people think that all older adults get depressed. And it turns out that as far as resiliency goes and being successful in one's life, it turns out that the most important thing are people who enter our lives and have a positive relationship with us. And those can be brief or long-standing, but having at least one major relationship that is a positive force in your life is all it takes for somebody to succeed in childhood. And it turns out that the more positive relationships you have, the more likely it is you're going to do well emotionally. And what can make for healing really is gratitude, forgiveness. And it turns out that there is something special about loving a particular person that has a very positive impact on humans. And one of the interesting things to me is it's not actually how much money you have, although certainly having enough to get your basic needs met is necessary. But beyond that, it turns out that learning how to play and be creative and use that part of your brain is more important and more predictive of successful aging than income. And along those lines, there was a very long-standing study done of both men and women headed up by a group at Harvard. And it turns out that a good marriage at age 50 predicted positive aging at age 80, but what your cholesterol was did not predict positive aging. Alcohol abuse is amazingly damaging and is perhaps the most damaging thing one can do. Although there is a little bit of a grace period for those who drink too much during adolescence. If they get past that, it doesn't seem to be so damaging. And then subjective good health is much more important than objective good health. So it's not how many medical problems you have, it's whether you view yourself as sick and disabled, or whether you view yourself as someone who is able to take agency in your own life. So whenever I talk about depression, one of the first things I say is you really have to differentiate between sadness, which is not a depressive disorder, and an actual illness. And the illnesses that make up the depressive spectrum of disorders are pervasive, they have persistent symptoms, and there's a wide range of symptoms that are present. And so specifically, having a negative view of events, people, life, feelings of worthlessness, feeling incapacitated and unable to talk, unable to act for yourself, unable to do things, guilt, sleep disturbance. If your mood is low in the morning and gets better over the day, that is actually consistent with most people who have severe depression or depressive illness. A loss of energy, problems concentrating, impaired ability to work or get things done in your day-to-day life, poor social functioning. Psychomotor retardation, so that slow movement, is particularly consistent with a severe depressive illness. Pessimism, feeling like you're better off dead, having thoughts of suicide, actually trying to harm yourself or kill yourself, and being fearful that you are severely ill or that you believing that you have something. So people have killed themselves because they thought they had cancer, even though they might not have. Things that increase our risk of depression are losses, stressful life events, having poor social support, physical illness, and then various family factors and genetic factors. So the ICD-10 criteria, ask a person if they have low mood, and if they do, really the next three questions: how low is it? How bad is it? How long has it been going on? Have you lost interest in things? Are you more tired than usual? Really, if the mood hasn't been going on for weeks or longer, it's not yet consistent with a depressive illness. And then, have you lost confidence in yourself? Are you feeling guilty? Do you have concentration difficulties, sleep problems, changes in appetite or weight? And do you feel that life is not worth living? So with ICD-10, they mild, moderate, and severe have to do with how many criteria you have and how severe they are. So it's a little different than the DSM-5 definition of depression. And there are a lot of different variants of depression. There's certainly major depressive episodes that occur in major depressive disorder or in bipolar disorder. There are depressive episodes that don't meet criteria for major depression, which has to do with the DSM-5. There's lifelong mild fluctuating depressive mood called dysthymia sometimes. And then there's, just dysphoric mood. You can have sadness or depressed feelings, but not have an actual illness or meet criteria for an illness. And then, of course, grief and sadness can be mistaken for depression. Interestingly, it's very easy to miss the diagnosis. And one of the things that's true is lots of people who have an episode of, in this case, major depressive disorder or major depressive episode, a lot of those episodes will remit even without treatment, but many of them don't remit without treatment. What about a person makes us most likely to miss the diagnosis? Well, if they have lots of somatic symptoms, so if they complain of various physical aches, pains, and challenges, their physical problems can often hide the depressive symptoms. Stigma on the part of people just not wanting to talk about, not wanting to be thought of as having some sort of mental defect or illness. Believing that your doctor isn't the right person for you to talk to or doesn't have time to listen to you. If you've been depressed your whole life or for many, many years, it's hard to know that that's not the way it's supposed to be, and that's not the way it always has been and always will be. So, sometimes people just don't recognize that there's anything wrong with how they are because it's how it's always been. And if a person has less overt symptoms or less typical presentation, it's also easy to miss it. And if the person themselves doesn't have insight doesn't believe that their symptoms are related to a problem, they're more likely. As far as providers go, people who are more accurate diagnosers make more eye contact. They may be in as much of a hurry as everybody else, but they show fewer signs of that. They're good listeners, and they ask particular kinds of questions. Less accurate diagnosers really ask lots of closed questions, yes/no questions, and sort of rate this rather than more open-ended questions. And they ask questions derived from a theory rather than sort of having a conversation with the patient. Whenever you do assess, you want to assess for the severity of symptoms, the duration, what is the person's social network, what are their views of themselves, the world, and future? Are they having suicidal thoughts? What's their past history? Because more than 50% of people who have major depressive episodes have recurrent mood episodes throughout their life. Are there any external factors that are affecting their symptoms right now? And then biological features, or what we call neurovegetative symptoms. And one of the reasons those are so important to note is because they predict positive response to medications. So, specifically picking up on verbal clues, asking people what they might have meant by something, sometimes enlarging what a person says, and then always summarizing what you think you heard and asking a person, did I get that right? And having them verify that. And it does turn out, it does always help for those of us who are able to be empathic. In older adults in particular, one of the things that is true is that a major depressive episode is often followed around 2 to 3 years later by a diagnosis of Alzheimer's dementia. So many people who have Alzheimer's dementia will have had met criteria for a depressive illness in the couple years prior to their Alzheimer's disease. That doesn't mean that everybody who's depressed who's older will get Alzheimer's. It just means if you're going to get Alzheimer's, it's quite likely that you will have been depressed prior to that. And then vascular risk factors, ASCVD, et cetera, hypertension, high blood pressure, cholesterol issues, those vascular things all make depression more common. And older adults who have a major depressive episode have trouble making decisions, and they're not able to consider information as fully. One way to talk to people about treatment for depression, some people advocate talking about pills for symptoms and talking for problems and for problem solving. So pills for the symptoms, and then learning new skills in problem solving is what talking or psychotherapy can be beneficial for. It is important to explain to patients that depressive illness is not the same thing as just being sad, and that it actually is involved with changes in your brain. And explaining that to people and explaining that all of the symptoms are originating from the brain can be very helpful and destigmatizing. It's important that patients know that antidepressants are not addictive. They're not habit forming. You're not going to be able to buy them on the corner from the street from the drug dealer. Antidepressants do take 2 to 3 weeks to begin to work. And once a person reaches full remission, so all of their symptoms have gone away, you really want to continue medications for 6 to 9 months in order to decrease the risk of a future relapse. If this is the very first time a person has had a major depressive episode. If a person has had more than 2 and certainly more than 3 episodes, the recommendation is for lifelong treatment with antidepressants. Doesn't mean you have to do it, but that is the recommendation. as far as explanations for patients, you know, this is just sort of general good advice for patients whenever you're going to prescribe a medicine. You want to explain the common side effects and that they may or may not happen. They usually are mild and they usually go away on their own. But if they don't resolve, you know, encourage the person to reach out to the prescriber. It's important to note that people who are severely depressed are not going to be able to engage in talk therapy until their symptoms are a little bit better. And that's why often you want to start a medication before psychotherapy. For people who have mild major depressive episodes, they may not need medications, and you can start with talk therapy. And it's regular follow-up is really important. It's been shown that if there's a follow-up from the provider's office every week after starting an antidepressant, the number of people who continue to take the antidepressant long enough to get a benefit is much higher. So they don't necessarily have to touch base with the provider, but even if someone from the office calls them in a week to check in, ask about side effects and things like that. You know, one way to explain to people talking therapy is about solving problems, helping a person learn how to solve problems that are solvable, learning how to cope with problems that can't be solved, and really having someone to bounce ideas off and to talk about issues with, that being the therapist. And one of the key things before ending therapy is to talk about future, you know, what might happen in the future, and to work on developing some contingency plans in case symptoms return. So, and here's 3 references. They're actually fairly old. I do have lots of newer references, but these particularly I thought were really good for non-mental health professionals to sort of look at, and we're quite practical. I'm a big fan of practical things. So here are some resources. There is the Institute on Aging runs something called the Friendship Line, and hopefully some of you guys have heard of that before. It's 24/7, 365, so 24 hours a day, 7 days a week, every day of the year. They're trained staff. It's both a crisis hotline as well as what we call a warm line, which means, you know, when somebody is feeling lonely or overwhelmed, an older adult or somebody with who is disabled, they can call this number and just have somebody to talk to. And it's a person who's trained to have conversations. And really, they're targeting people who are feeling lonely or isolated, people who are grieving, who are depressed, anxious, or thinking about death or suicide. And so that's one great resource. And you can, a provider can actually call and set up with the Friendship Line. They can actually call out on weekends to check on people. That has to be set up by the provider's office ahead of time, but that is a resource that they provide. When we talk about medications, I'm gonna, I can't turn people into psychiatrists in one short talk, but I just wanna review some general principles that seem to me to make sense and hopefully will make sense to you. So when a geriatrician or somebody who specializes in working with older adults thinks about things, and when you read something written by them, the principles are really going to be start low and go slow with medications. Geriatricians have more experience with side effects than actually with seeing psychotropic medications work for frail older adults. And they're less familiar with the evidence and have less experience with medications for mental illness than mental illness healthcare providers, which makes sense. They're also less tolerant of side effects. One of the things I have noticed in my practice here at Elder Place is that Our primary care providers, whenever a person has a problem, they always first look at the psychiatric medications as a possible source of the problem rather than, for instance, the cardiac medications. And I think that a lot of that just has to do with comfort and experience. When a psychiatrist or a psychiatric nurse practitioner thinks about medications and thinks about treating someone, they are very much trained to focus on safety, safety, safety. Is this person going to kill themselves? Are they going to kill somebody else? Are they at risk of, really severely harming someone else because of a mental illness? And that, so it's just a whole different perspective. And when that is your perspective, you're much more willing to encourage people to continue medications, even if they are having some side effects, if it's going to stop somebody from completing suicide or completing homicide or harming someone else. And so it's just it has to do with who they see. A primary care provider or a geriatrician is going to see people who have less severe illness, generally speaking, while a mental health provider is going to have more experience and is more likely to see you if you have more severe illness. So we all come to any discussion with our past experiences and or biases with us. We bring those with us. One of the other things to keep in mind is certainly as a psychiatrist, one of the things that I have seen too many times is our lives or livelihoods or entire family relationships that have been destroyed by people with chronic mental illness that was not well treated. And so it just brings a whole different level of concern when I consider treatment. Also, people who are specialists are more likely to have lots of experience with talking about and weighing risks and benefits and alternatives and really highlighting what are the quality of life aspects to treatment. Sometimes quality of life is so impacted by side effects that you have to stop the medicine, even if a person is going to have significant symptoms of the illness. Other times, quality of life is so impacted by the illness that tolerating even moderate side effects might be the right answer. And it's very person dependent. People have very particular belief systems and are willing to tolerate one thing or another. And so you just have to work with the person. I want to just briefly touch on when to use an antidepressant. And specifically, I think of using antidepressants when people have major depressive disorder or bipolar disorder sometimes. And maybe if they have very significant dysthymia that has a significant functional impact. I don't think if you don't fall into one of these three categories, I tend to be pretty reluctant to recommend using an antidepressant. And even in these three categories, if your symptoms are not moderate or severe, I think it makes sense to do something prior to trialing a medication. When definitely not to consider an antidepressant, if somebody is having acute grief, they may need something to help them sleep. They may need resources to help them get through acute grief. But if grief is super severe, when someone is laying in their own excrement because their grief is so severe, that is not just grief. That's sort of gone past the point of being a normal grief reaction. So there are some times where grief leads to something else. But if it is really explainable by loss, that's when support, psychosocial support is important. When people are having sadness over situational problems, or if if their symptoms don't actually meet criteria for an illness, I think it makes sense to be very hesitant to consider an antidepressant. I'm just going to share with you a little bit about how I think about antidepressants. Antidepressants work on 3 different neurochemicals in the brain. They work on serotonin, which is chemically abbreviated 5-HT. They work on dopamine, or DA, or they work on norepinephrine, or they work on some combination. And one of the things that I believe is most likely to be true is that it is not a deficit of these neurotransmitters that cause major depression, major depressive illness. So this is Maureen Nash's personal theory, although it's also shared by quite a few other people, and I didn't originate it, so I wasn't the first person to think of it. But, you know, there are, within 24 hours of taking an SSRI, for instance, like sertraline or citalopram, Celexa, Zoloft, within 24 hours of taking those medications, serotonin levels in the brain synapses are restored to a normal level. But people who have a depressive illness are not better within 24 hours. So it's not the neurotransmitter deficits that are seen in people who have major depressive episodes are not likely the actual cause. Something else likely has changed in the brain, and over time, those changes that led to the illness lead to these neurotransmitter abnormalities. We can treat the neurotransmitter abnormalities, and something about that and then sustaining that treatment is what actually leads to remission of symptoms or of the entire illness. So, so it really isn't totally like a chemical deficit that leads to depression, just like it isn't a chemical deficit that leads to rheumatoid arthritis. It's more along the lines of when you have a depressive illness, these are the things, right now, these are the only tools in our toolbox. So if you think about serotonin, there are various medications. So the SSRIs, the selective serotonin reuptake inhibitors, are perhaps the most famous serotonergic medications. Venlafaxine or Effexor, when you use it at a dose less than 225 milligrams, the only one of those 3 neurotransmitters I mentioned that is affected is serotonin. It actually doesn't affect norepinephrine until you get to 225 milligrams or greater. Trazodone, nefazodone, and some newer antidepressants also work only on serotonin. Some of the tricyclic antidepressants, which were the first medications that we used for depression, they primarily work on serotonin, but we don't use those in older adults very often because of some other side effects. A class of medications that is fairly old but rarely used anymore are the MAO inhibitors. Those medications tend to work on serotonin. One of the key things to keep in mind is that restless legs and movement disorders are actually relatively common in people who are on serotonergic medications. And I don't think we started to see all those ads for medications for restless legs until people were commonly using and taking SSRIs, actually. So I think one of the key things is if somebody develops restless legs and another movement disorder and they're on a serotonergic antidepressant, one of the first things to consider is, should I lower the dose or take them off or change to a different medication, rather than adding a separate medication for restless legs. Sometimes that is the right answer. Sometimes it's not related to the serotonergic medication, but I find that in primary care, that's one of the side effects that's less well known. Norepinephrine is the other major neurotransmitter involved with antidepressants. Bupropion, which is also known as Wellbutrin, affects both norepinephrine and dopamine. Nortriptyline, which is a tricyclic antidepressant, but it typically affects mostly norepinephrine, and among the tricyclics, it's probably the best tolerated by older adults. Atomoxetine, they didn't test it on major depression, and so it's not labeled for use of that, so it's an off-label use. But if you look at it chemically, there's no reason to think it might not work as an antidepressant because it works on norepinephrine, similar to other antidepressants. Noradrenergic agents are the best choice, the best first choice for people who have Parkinson's disease, who also have depression, or people who have Lewy body dementia. Those illnesses do tend to do better with noradrenergic agents rather than serotonergic agents. And that's the actual group of patients who are at highest risk of restless legs from a serotonergic med. Many antidepressants work both on serotonin and norepinephrine. And so mirtazapine, duloxetine, venlafaxine, and there are other newer agents. There are dozens of antidepressants at this point, and I tend to use mostly medications that are available generically first, whenever possible. At this point, there's not a lot special about new medications, except they may have a more favorable side effect profile. There's no therapeutic benefit from something because it's newer, at least not yet. There's some hint that we may be soon seeing some antidepressants that have a different mechanism of action, but we don't have any on the market currently. And then dopamine. So dopamine is something that helps us pay attention and focus. It's how we treat ADHD, attention deficit disorder. So stimulants affect dopamine. They have been discussed in and studied in older adults, augmenting an antidepressant. And that it turns out that they can be very effective for older adults if you add it to somebody who's already on a serotonergic, noradrenergic, or medication that affects both. I would caution one should never use a dopaminergic agent in someone who is psychotic unless you have significant experience, because they can cause psychosis. And generally speaking, although they may make a person feel better or even feel very good, they are not sufficient to treat a major depressive disorder. So you're not going to get somebody into remission just by an agent that affects dopamine. So let's say I start an antidepressant and somebody is feeling better and they have a 50% reduction in symptoms, or even a 67, 2/3% reduction in symptoms, but they just are still symptomatic. What can I do? And there's multiple different things that are recommended. The best evidence is for actually adding a little bit of lithium, between 150 milligrams and 600 milligrams. So those are much lower doses than we use to treat bipolar disorder. But lithium is a very small molecule, gets into many different brain cells and gets through the blood-brain barrier very well. And so we really don't have any other medication that is quite like it. There is evidence in older adults for using like methylphenidate or mixed amphetamine salts added to an antidepressant. If someone is on an SSRI and they have had a pretty good response, but when a couple months out, their response seems to decrease, a lot of times adding buspirone can help with that. SSRIs don't actually give your brain more serotonin. They just make the serotonin in your brain stay around longer. And it turns out that Buspar or buspirone and lithium both actually do increase the amount of serotonin in your brain. So they actually have added benefit. There's a lot of talk about adding atypical antipsychotics or a second antidepressant when somebody hasn't responded to fully to a trial of an antidepressant. Generally speaking, I try and reserve that for people who have failed one of the top 3 augmentation strategies above. I don't think those are first line, although there are a lot of drug reps who might offer that. There is evidence for using atypical antipsychotics or a second antidepressant, but I do think you have to be careful. They have a whole host of other side effects. What about people who have bipolar 1 disorder? I mean, a common part of bipolar 1 disorder is depression. Yet you never want to use an antidepressant for somebody with bipolar if they are not on a therapeutic dose of a mood stabilizer. And specifically, you never want to use an antidepressant to help with sleep or appetite or pain in someone who has had repeated episodes of mania. It's just very dangerous. Their brains don't tolerate antidepressants very well. Antidepressants can induce mania, so you have to be careful with that. The best evidence for treating depression in people who have bipolar type 1, people who've had significant manic episodes in their life, is for lamotrigine or Lamictal, which it was originally developed as an anti-seizure medicine. The one thing to know about lamotrigine is that it can cause a Stevens-Johnson type rash, which is a life-threatening kind of rash. It's not that common, but it certainly can happen. The other thing to know is that lamotrigine and Depakote are very dangerous together and really shouldn't be combined unless you're very experienced or you're working with a consultant who can help you do that. It's very tricky to do that without causing significant side effects. Lithium is the only mood stabilizer that is also an antidepressant. You do have to watch out for renal function, kidney function whenever you're using lithium. Quetiapine and some of the newer atypical antipsychotics do have evidence for treating major depressive disorder in bipolar 1. So I realize I've sort of gone over quite a few things here. I have a couple more slides that I'm going to try and get through and maybe leave around 10 minutes for questions at the end. This is sort of my recipe for using an antidepressant. I pick one. If somebody has had a past evidence of a past episode of depression and responded to a medication in the past, that's the one I always start with. You want to have an informed consent discussion before you start any medication, including an antidepressant. If a person has a family history of bipolar disorder or a personal history of hypomania or mania, you definitely want to review that with the person and maybe even their family before you start an antidepressant, so that at the first sign of hypomania or mania, you can stop it. You want to start low, but you want to continue to increase the dose weekly. And it's really important to have phone check-ins if you're in a primary care practice and you're starting an antidepressant. You want at least a 50% or greater response in symptoms to show that a person is responding to a medication. If you've started something and you've increased the dose and you haven't gotten to 50% or better decrease in symptoms after 8 to 12 weeks, so if it's a less than 50% response, you really want to consider switching. If you have 50% or greater response, but you're not in remission, you want to consider augmentation with some of the strategies mentioned on the last couple slides ago. If there's been no response at all, or really, less than a 25% improvement at 4 weeks, you want to change. And how I do it is I tend to start with a serotonergic medication, often an SSRI. If I don't see benefit at 4 weeks and really a person hasn't changed and I've been increasing the dose over those 4 weeks, that's when I would switch to a norepinephrine noradrenergic agent like bupropion or nortriptyline. That's sort of how I do it. And then if I don't get a response to either one of those agents, that's when I go to one of the mixed agents like duloxetine or mirtazapine. The biggest quote unquote mistake or treatment error that is seen in primary care is not treating to remission. So people get a little bit better and are left on a low or medium dose of a medication that isn't increased with a goal of trying to get them into remission. Just again, another, when does an atypical antipsychotic make sense? Well, number one, if the person is psychotic, it's very reasonable to treat with an antipsychotic. If a person has a very obsessional quality to their depression, they have obsessional thoughts that they just can't get out of their mind, that's a group of people when an atypical antipsychotic added to an antidepressant makes sense. If a person has bipolar disorder, using an atypical antipsychotic instead of an antidepressant makes sense if they can't take lamotrigine or it didn't work for them. Just one word about suicide. You know, three of the things that indicate a person is at immediate risk of suicide. If somebody says, I want to die, I am going to kill myself, so that's a big warning sign. If a person is noted, tells you that they're looking for a gun, they're looking for a knife, they're looking for a place to run their car off the road, a cliff or something, or a family member tells you that, that's a very large warning sign. Or if a person is just totally hopeless or tells you they have absolutely no reason to live. Those are the three things that really should make you very concerned about suicide. So, and then I do have a couple slides at the end of the presentation that really review some things about suicide, and there are some resources if you want to look at them. So it looks like it's 12:53, so I think that we have about 7 more minutes or so for questions.
Now's your chance, folks. I'm sure somebody's sitting there thinking.
I was trying to, this is Dr. Fillmore, and you've helped me so much with my other patient, and then he decided to take a different provider in town. But anyway, we started him properly. Anyway, buspirone, is that considered an SSRI? Or I'm not quite sure the mechanism buspirone.
Yeah, that's a great question. So buspirone is not an antidepressant. It actually was first approved for treating generalized anxiety disorder. And it does work on serotonin, and specifically it works, to be technical, on the 5-HT2A. So that's a very particular serotonin receptor. There actually are at least 10 different serotonin receptors that we know of. So 5-HT2A is one of those receptors, and Buspar blocks that, as well as increases the neurons who manufacture serotonin. So it increases the amount of serotonin in the brain and blocks 5-HT2A. So that's why, in particular, because of the way SSRIs work, it's a good augmenting agent for SSRIs. I don't think there's really good evidence for it augmenting any other kind of antidepressant, and it just has to do with the the particular serotonin receptors it affects in the brain that makes it synergistic and working well with SSRIs. Whereas when you use like methylphenidate at a low dose, 5, 10, 20 milligrams, or you use lithium at a low dose, you know, you can really augment most antidepressants with them.
And tell me, if someone you know has a good effect on nortriptyline and they're getting older and maybe they think that maybe something like atomoxetine might work, would you substitute it, or would you keep the nortriptyline was for sleep actually, but also depression symptoms? Would you add it on and do it a morning dose since it's more like an amphetamine kind of effect? What about those two together? It would seem like if people are norepinephrine responsive, that maybe it would be a good idea to stick with it.
Yes, and that's actually exactly how most people seem to work, and that's exactly how I think of it. People have major depressive episodes that are either responsive to serotonin or responsive to norepinephrine or need both. But so if somebody has a noradrenergic responsive type depression, so a typical thing would be, so you have somebody who's on nortriptyline, but then they develop urinary retention because of it, because of the anticholinergic effects of nortriptyline. You can either lower the norepinephrine to the point where they don't have urinary retention, but if symptoms of depression come back, then you might want to add either atomoxetine in the morning or maybe a low dose of bupropion in the morning to augment the nortriptyline, to augment the noradrenergic effect. I have seen a lot of people who respond to both bupropion and nortriptyline, but you know, for one reason or another, can only tolerate one of those agents.
Okay, and I always think using dopamine. I mean, I hate to get people dependent on dopamine, and then if you take them off, then they maybe they get Parkinson's or something like that. I'm always feeling a little cautious about that, though I have no reason to have read that in the literature. I mean, is there any thoughts about that?
Yeah, so stimulants are certainly addictive, and because of various qualities about them. Generally speaking, when we use them to augment an antidepressant, we're using pretty low doses, and it's unless somebody is diverting it, it's not usually a problem. But stimulants add to dopamine in the synaptic space and can increase the amount of dopamine in the brain, but they don't actually change the neurons in any way that is going to make the neurons produce more or less dopamine. So they can't, I'm unaware of any evidence that they can actually induce Parkinson's disease, which is actually caused by abnormal Lewy bodies in the dopamine, in various neurons that in the movement centers, the neurons that control the movement centers, they get these Lewy bodies inside the neurons that cause those neurons to not work. So I'm unaware of stopping a stimulant being able to induce an episode of Parkinson's disease. There may be something like that in the literature. I've never seen it. I do think in older adults in particular, there's this executive functioning dysfunction. So that trouble making decisions, trouble with focus, trouble with attention. So, and those are actually the kind of things that dopamine helps with. So there are, as we age, we lose dopamine, even whether you have a depressive illness or not. So I don't know if that helps in how you're thinking about things.
Okay, sorry, I'm like taking all these questions from you, but I really appreciate it. With atomoxetine, I haven't used it all, so I have a lot of curiosity about this. It's actually, I haven't used it with kids either with ADHD or anybody with ADHD. It's not actually a stimulant, right?
No, it's not.
So there wouldn't be an addictive component to this.
Correct.
And it's not actually a restricted medicine. I haven't prescribed it, so I really got to know about this. So tell me anything I need to know.
Yeah, it's like bupropion, which is marketed as an antidepressant under the name Wellbutrin, and bupropion is marketed under some other different name as an ADHD medicine, and has an FDA-approved label. And atomoxetine is also marketed for ADHD.
Sure like those better. All right, dear, you've answered wonderful questions and you've given a great talk. I appreciate it. And everybody has to go to clinic.
Yep, and I do too, as it turns out.
So thank you, Dr. Nash. And we just want to put it out there for folks that we're working on, again, more topics. So we want to hear from you of what you might want to hear from Dr. Nash. And on that note, we hope to hear from folks in March. We'll be back same time, same place, March. Stay tuned. Flyer to follow. Thanks, everybody.
Thank you, everybody.
Thank you, Dr. Nash.
Very good.